LHMC Hospital, New Delhi, in the year 2022. Sir is a member of Indian Academy of Pediatric. Thank you so much, sir, for accepting our invitations at the last moment. So I'll just over the platform to sir for the presentations. You can sit there, focus the camera. You sit there only, it's okay. I'll just focus the camera.
Good afternoon, everyone. I hope you can hear me. If you cannot hear me, please do tell. Today's session, I would like to thank Ms. Nanika also for allowing me to take up this class and in a short period of time, but still for the benefit of all the nursing staff and all the paramedics in the Northeast and all over India also. I'm very grateful to take up this class. So I'll begin regarding this basic mechanical ventilation. And if you see this child, this is just a cartoon where there is a child, there is a mask and the corrugated tube attached to the ventilator. This is not exactly how it is, but as you will see more in your ICUs or intensive care unit, or even a patient in videos like you will see later in the slide later on. I will start with a question like a sick child of 5 years old with scrub typhus that you have admitted in a high dependency unit from emergency has crashed and you have been called to attend the scene. Nurses are giving oxygen by an rebreathing mask and still his saturation is just 74%. And during that time also the child is unresponsive. What would you do? That's the question you should ask and you should think. And with this, after this class, you will be able to answer. The next scenario is that a 6 months old baby of 5 kg, he or she is having pneumonia and with severe respiratory distress, saturation on high heated humidified high flow nasal cannula with 10 liters per minute and FiO2 of 100% is just 82%. During that time also, we have tried CPAP, but still there is hypoxia and we are having a concern that this baby might get tired and go to respiratory failure. So what are your options with these two patients? All of you must have seen about these kind of instruments where this is the laryngoscope, this is the ET tube with a cuff, and this going inside the trachea beyond the vocal cord, though the vocal cord you cannot see here. And this is the ventilator machine with the company Dragar. There are so many company also, but what we usually use here also are of the company Dragar. What are the indications for mechanical ventilation? When should we go for mechanical ventilation? Ventilation is important when the patient is unable to breathe by himself or herself. This is needed when the patient needs to be help in bringing out air, breathing in air and breathing out air out of the lungs. The second indication is to increase oxygenation by increasing the airway pressure, meaning that like you have seen in a high heated humidified high flow nasal cannula, though pressure is there, but still the oxygenation is 100%, but still the airway pressure we still need. And supporting the respiratory muscles to prevent fatigue. Just like patient in that child, we have concern regarding the respiratory fatigue. So to prevent from respiratory failure, so we need to, these are the indication for mechanical ventilation. Apart from this, also there are other ways, like that patient who is unresponsive. We need to maintain the airway. In that way also, we have to intubate the child and put on mechanical ventilation. These are the two machines. This is usually used for children, younger children and older children from 1 year of age and above. And this is usually used on the right side of the screen. It is used for unit ventilator up to 6 months or up to 1 year of age. And on the left side of the screen, you can see that's the Dragar ventilator, which has a knob and all the parameters and the graph which you can see there is for older children or from more than 1 year of age. How to do settings in a ventilator? There are different modes you should know, and other variables will tell you that when we go forward, how to ventilate in certain ways. We have two modes. One is traditional modes and one is newer modes. In traditional modes, like when initially mechanical ventilation was invented, we got only three. That is continuous mandatory ventilator, also called as CMV, intermittent mandatory ventilator, that is IMV, and assist control. And the newer modes are SIMV mode, synchronized intermittent mandatory ventilators, PSV, pressure support ventilator, CPAP, that is continuous positive airway pressure, BiPAP, that is bilevel positive airway pressure, PRVC, that is pressure regulated volume control, and NAVA is neurally adjusted ventilator assist. So these are the newer modes of ventilator. In the traditional mode, why there is a change from traditional to newer modes in such a way? Because in traditional modes, it does not have any synchronization. It cannot synchronize with the patient requirement, whether the patient is breathing. Sometimes the patient breathes on his or her own by herself while on ventilator. So these traditional modes, it cannot synchronize with those breaths. So we'll see further what are the newer modes, such that in continuous mandatory ventilator, we will see later on that the breaths are breathing in and breathing out is given by the ventilator. In intermittent mandatory ventilator, it is given by the machine. And in an SIMV mode, it is given by the ventilator together synchronized with the patient breaths. In pressure support ventilation, we are giving pressure support to the ventilator. In CPAP and BiPAP, the patient should be having spontaneous breathing. During this time, the difference between CPAP and BiPAP is that in a CPAP, there is a continuous same pressure which is given with the PEEP of minimum 5. And in the BiPAP, the difference is that during inhalation, there is pressure given, and during exhalation, the pressure has decreased. In a PRVC, that is pressure regulated volume control here, the pressure is regulated as per requirement of the patient. And NAVA, that is neurally adjusted ventilator assist. It has a probe which is attached to the diaphragm, where depends on the diaphragm contraction, then the ventilator machine will give breaths accordingly. So in CMV, IMV, and in CMV and IMV, inspiration and expiration is given by the ventilator. The breaths both are mandatory breaths. We set for CMV mode, we set the ventilator breaths, like for example, the respiratory we set at 30. The ventilator will give 30 breaths, and extra breaths above this one will not be allowed by the ventilator. And in IMV mode, even though after setting the respiratory rate of 30 breaths given by the ventilator, there are spontaneous breaths which are allowed. In assist control also, the difference is that between these two is that in inspiration is given by the patient, is started by the patient, expiration is initiated by the ventilator, and it allows assisted breath. Assisted breath meaning that if the pressure is, when the patient started to breathe, the machine will help in putting more pressure in the airway, giving more pressure to the airway pressure. And the assisted breath also for those spontaneous breath, they allow this by this mode, and it will assist with every breath. In SIMV mode, the inspiration is initiated by the patient and expiration is initiated by the ventilator, and all the breaths are assisted. And yes, extra breaths are allowed in this with this mode of ventilator, and especially with spontaneous breath. In pressure support, here we give only support to the patient. In CPAP, we give support. We give only pressure support to the patient, and both inspiration and expiration are taken up by the patient. And all the type of breaths here, spontaneous breaths. That means the patient should have spontaneous breathing while putting on these modes of ventilator. And extra breaths are allowed because the patient is taking breath by his own. And yes, above the set rate, though the set rate are there, spontaneous breath is allowed if more than the setup rate. There are different control variables. What are these control variables? These are set parameters which you should keep on a ventilator, which will remain constant, above which these parameters there might be injury to the lungs of the patient, and other variables, depending on these constants, the other variables may change, such as pressure control, where here the airway pressure is set, and the ventilator gives the set pressure in each breath. Suppose the pressure control, we keep the peak inspiratory pressure of 12, like in children, neonate, or we begin in older children, like in 16 or 15 centimeter of water. Above that, the ventilator will not give. Then volume control. Here we set up the tidal volume, the volume which the ventilator should give to the patient, and the ventilator give this set of volume in each breath. How much pressure should we give? That is called as pressure control. And how much volume should we give? It is called as volume control. In the above diagram, this is the volume control. Here we set the FiO2 of 21% and tidal volume of 140 ml per breath, and inspiratory time of 0.75 seconds, respiratory rate of 30, a PEEP, that is a positive and expiratory pressure of 5, and the delta P, which is the pressure support of 10. How do we get this delta P10? We'll go later to pressure control. In pressure control, the diagram below is about pressure control. Here the FiO2 is 21% in the peak inspiratory. This PI and SP is the peak inspiratory pressure. That means above which this pressure the ventilator will not give. We set a ventilator of 16 centimeter of water, above which the pressure during inspiration, the machine will give a pressure of 16 centimeter of water, inspiratory time of 0.75, respiratory rate of 30 breaths per minute, a PEEP of 5 centimeter of water, and delta P of 10. Here, how do we get the delta P? We will see later on. The formula is PIP, that is the peak inspiratory pressure minus the PEEP. Suppose here if the PIS NSP is 16 and the PEEP is 5. So 16 minus 5 comes around 11. So the delta P is around 11. But here the ventilator is set at 10. What are the other limits that the ventilator will not allow this variable to go beyond this point? Like I said before, that if we set the ventilator pressure at 20 centimeter of water, this is above this pressure, the ventilator will not give because it might cause injury to the patient, such as volume trauma or pressure trauma. How maximum volume allowed to be delivered? If we set the tidal volume to 200 ml every breath, the ventilator will not deliver beyond this. How much pressure is allowed to be reached? This is set by the peak inspiratory pressure. Now, this is the graph regarding the inspiration, the different phase variables during inspiration, expiration. If we see this, can you see my arrow?
You can write yes or no. You're able to see the arrow? You can write yes, yes. They are able to see.
Okay. This red line, this black line, this is the minimum pressure inside the alveolar space. The red line above it, this is from the beginning of y-axis. From the beginning of y-axis to this purple plane, what you can see is the expiratory phase. Now, when the patient is starting to take breath, this is the initiation phase. So what will happen is that the ventilator what will happen when the patient breathe in is that the balloon is inflated. So what happened inside the alveolar pressure? The alveolar pressure will drop down such that the atmospheric pressure from outside will enter in such a way that pressure, just like in concentration gradient, the concentration, any molecule will move from a higher concentration to a lower concentration. Same as pressure also, the air will move from a higher pressure to a lower pressure. Now, when the balloon is, when the lungs are trying to inflate, when you take inhalation, when you try to inhale air, so what happened? The alveoli will open, will try to expand. What happened to the pressure inside? The pressure will drop. During that time, air will enter from outside through the nose, airway, and will enter into the alveolar space. During that time, what happened to the alveolar space? The pressure will drop down. And in that time, the ventilator will get triggered and will get stimulated, meaning that this patient is needing breath. So inspiration, the ventilator will give breaths and the pressure will increase. Beyond this, the pressure will not go. And after that, there is a plateau phase in such a way that the pressure is given breath during this time and will continue. It will not go beyond. And after 0.5 seconds, or according to the set inspiratory time, then expiration will start. During that time, the pressure given by the ventilator will drop and expiration is allowed, such that this red line which drop down is allowed, and same cycle will come. So this dip here, it means that there is, if you see this dip here, suppose in a patient who is not having obvious spontaneous breathing, with this king here, you can say that the patient is having some respiratory efforts. Now, there are different phase variables such as trigger and cycle. Here, trigger, this is a variable used to initiate inspiration, like we saw before that dip. What starts that breath? It can be a time trigger. Suppose in 1 second, we said that the inspiration is 0.5 seconds and the expiration is 0.5 seconds. So after 0.5 seconds of inspiration, then expiration will start. And after 0.5 seconds of expiration, inspiration will start. It can be time trigger, it can be pressure triggered. Pressure triggered meaning that if depends on the pressure inside the lungs and the flow is more sensitive, meaning that as long as there is flow, if there is a decrease in the flow, meaning that the pressure, the ventilator will get trigger that this patient need breaths. And cycle is used to determine when to inspire and when to go for expiratory phase. So this is the time. Time is the only variable which determines the cycle in a ventilator. Now we have the baseline, where the pressure does not go below a certain level in the expiratory phase. Here, the baseline here is when we set the PEEP such as 5. Below this PEEP 5, the pressure inside the lungs will not go below this PEEP, because if it goes below this PEEP, so there will be collapse of the alveoli. And there are other conditional variables which need to be used, such as synchronization. So if we see here also, here the pressure, what happened is that the pressure, this is the PEEP. Now the patient will start inflate, taking in breath. So what happened to the pressure will drop down. Now the ventilator will what happened to the ventilator will sensitize and then will give the pressure. And then after inspiratory time, then the exhalation phase will start. And again, every time. There are different variables also to determine regarding oxygenation and ventilation. The difference is that ventilation meaning breathing in, breathing out. There is an oxygenation means that the concentration of oxygen. How do we define the oxygenation, or how do we tackle the oxygenation inside the ventilator? One is the fractional inspiration of oxygen. So the FiO2, whether starting from 21% like in room air or in atmospheric pressure, it is 21% of oxygen. Up to 100%, we can set the oxygenation. It also depends on the mean airway pressure, such as the peak inspiratory pressure. If we increase the peak inspiratory pressure, oxygenation will be more, such that concentration, just like concentration gradient in diffusion, from a higher concentration to a lower concentration, same thing like in pressure. If from an increased pressure to a low pressure, the diffusion will be more. Peak and positive and expiratory pressure, meaning that it is the pressure after the end of expiration, such that to maintain the alveoli in a non-collapsible state. That means to keep the alveoli expanded, not to allow them to collapse. That is the IE ratio. IE ratio will set in the inspiratory and the expiratory time. If the expiratory time is more, that means we allow exhalation more, and there is exhalation driving out of oxygen more. So there is more room for oxygen, and also the flow. In ventilation, the minute volume, tidal volume into respiratory rate is the minute volume in liters per minute. Tidal volume depends on the lung compliance also. If in a case where there is stiff ribs, so the lung compliance will be less. If in case the patient got muscle relaxant, so the lung compliance will be more. And the delta P, like I said before, delta P is the peak inspiratory pressure minus the PEEP. If the delta P is more, The ventilation also will be more. And the respiratory rate also will give about the ventilation. The basic parameters we should set in a ventilator is the PIP, that or the tidal volume. If you use pressure control, then you set the PIP, that is the peak inspiratory pressure. Tidal volume, that we'll see how much later on, how much ml per kg should we give, what is the tidal volume for different illnesses and patient. The positive and expiratory pressure we set in, usually we set at 5, minimum of 4 to 5 centimeter of water. The peak inspiratory pressure for neonate, it begins at 10. And for old adolescent, we start with 15, 16. Tidal volume for neonate, for children, it's around 8 to 10 ml per kg, or in a normal adolescent, it's around 10 to 12 ml per kg. Then the inspiratory time. After setting the inspiratory time, the IE ratio will come by itself. The machine will calculate the IE ratio by itself, and the expiratory time will minus from the inspiratory time. Then the respiratory rate, you should set in how much respiratory rate, how much respiratory efforts by the ventilator, or the number of breaths by the ventilator should be given in a minute, and the FiO2, that is the oxygen concentration with every breath. There are alarms we should set. One is the peak pressure, because why, even after setting the PIP, we should have other alarms. There might be a ventilator glitch also. So we should set the peak such that from ranges beyond this one, the ventilator should not give. And the minute ventilation. The minute ventilation we should calculate for each patient, that is the tidal volume into respiratory rate. We calculate the tidal volume such as 8 to 10 ml per kg into the normal respiratory rate. Suppose in a neonate up to 60 respiratory rate, we can take an infant up to 30, and the respiratory rate, spontaneous respiratory rate for each patient. Now this is the PIP, also known as the peak inspiratory pressure or the peak pressure. Delta P, it decides the tidal volume. How to calculate the delta P? It's peak inspiratory pressure minus P. If we set PIP 15 and P 5, then the delta P is 10. Same thing if we set PIP 20 and P 7, so the delta P is 13. So the delta P in pressure control, the delta P will determine the tidal volume. Here you can see the constant you can set is that in pressure control mode, you can set the delta P or the PIP and PIP as constant, and you will get variable tidal volume. But in a tidal volume control, you can set the tidal volume and the PIP. In this graph, you can see here same thing, like this is the PIP, the upper blue dotted line. This is the peak in inspiratory pressure. Above this, the ventilator will not give breaths, will not give the pressure above each breaths. And this blue area, blue box, this is the PEP. This PEP is helpful in maintaining the alveolar in expanded state. And the difference between this PIP and PEP, this is called the delta P. This will determine the tidal volume of each breath. The tidal volume for a normal lung is usually 10 to 12 ml per kg. For a diseased lung, 6 to 10 ml per kg. Because these diseased lung, they are prone for volume trauma or barotrauma. And for an ARDS, because in ARDS, the tissue is more fragile, so we need a lower 4 to 6 ml per kg of tidal volume. Now, respiratory rate, inspiratory time, and I ratio. We set the respiratory rate according to the physiological rates in infants, from neonates, infants, and older children. For neonate, we set not more than 60 breaths per minute. In infants till 2 months of age, till infants, we set not more than 40 breaths per minute. And in older children, we set up to not more than 30 breaths per minute. Usually, we set in infants 20 to 25 breaths per minute, and older children 15 to 20 breaths per minute. After setting the respiratory rate, we should also set the inspiratory time. After setting the inspiratory time, then the machine will calculate the IE ratio. The IE ratio we should keep is 1:2 to achieve 1:2 or 1:3. But we should not keep the inspiratory time below 0.4 seconds. What will happen when there is 0.4 seconds? You can type in the chat box. if the inspiratory time is below 0.4 seconds. Now the expiratory time. This expiratory time and I ratio we don't set. This is calculated by the ventilator after setting the respiratory rate and the inspiratory time. High IE time, what will happen when there is a high E time? When there is more expiration, what will happen? More carbon dioxide removal. So when there is more carbon dioxide removal, this is required in case of asthma, because asthma is a condition where there is obstruction in expiration. Like when there is carbon dioxide retention. Suppose there is a carbon dioxide retention, PCO2 is more than 45 in a patient and there is respiratory acidosis. So what do? We increase the expiratory time, that is the IE ratio is put to 1:2 or 1:3, such that there will be more of carbon dioxide driven out. If we set IE inspiratory time below 0.4 seconds, so what will happen? There will be an inverse ratio. That means less time to inhale and more time to exhale. So what will happen is that there is less time for oxygenation, less time for air to enter inside or for oxygen to enter inside. So that's why we should not keep it below 0.4 seconds. Now there are applied tips for oxygenation, FiO2. Now if FiO2 above 60%, this is not safe if used for days. Because why? Oxygen also will form oxygen radicals, and these free oxygen radicals, it is harmful for the body and also for the cells. Use other strategies. If FiO2 is more than 60%, what other strategies we should use? Number one is increase the mean airway pressure. What is the mean airway pressure? This is calculated by the ventilator also. If we, after adjusting the peak inspiratory pressure and the peak according to the delta P. Now, if FiO2 oxygen requirement is high, so we should use other strategies. Later on, it will be discussed in other class. The mean airway pressure. How do we get the mean airway pressure? By adjusting the PIP, the PEP, IE, and the flow. Now, a raised carbon dioxide is usually an indicator that you need to increase the minute ventilator. Just like I said before, when there is carbon dioxide retention, what else apart from increasing the IE ratio or increasing the expiratory time? Can you tell how to drive out carbon dioxide from the ventilator?
You can write down in the chat box.
From the alveoli?
You can write down in the chat box.
If there is carbon dioxide retention, apart from increasing the IE, changing the IE ratio, what other parameters can you set such that there is more of carbon dioxide wash out?
Increase rate.
Very good.
Okay.
Okay. So same thing, just like when you see a hyperventilated patient. So what happened in a hyperventilated patient? There is alkalosis, there is more of oxygen inside the body. So what do you need is that, what happened during that time when there is hyperventilation? So there is driven out of more carbon dioxide out of the body. That's why this in a ventilator also, what strategies we can use is then we increase the respiratory rate to drive out carbon dioxide from the alveoli. In pressure control mode, tidal volume is a function of the delta P. Just like I said before, the delta P, after setting the delta P, we will get the tidal volume in pressure control mode. More on regarding titrating settings and troubleshooting in different scenarios, this will be discussed in the next session. And this usually happens, this is very important for all the nursing staff and also even for us doctors also to troubleshoot or to tackle this problem when there is sudden desaturation. So what happened, what we use to have one mnemonic is DOPES. There is another S also. I'll tell, if you can tell me, you can type in the chat box. Another S is there. Number one, what we should check is the displacement. How do we check the displacement? Number one, if you can see this tube, If you see this tube here, it has markings. Okay. While having markings, we used to check. After intubated, we used to have marking that we set at 10 centimeters, we set at 12 centimeters, we set at 14 centimeters. There are marking here. How do we check for displacement? How do we know that the tube has displaced?
You can write down in the chat box. And those who have switched on the video, please.
How do we know that there is a displacement?
You can write down in the chat box. How you will know?
So one thing you can know is by looking at the numbers here, the labels. Here it's numbering as 12, 14. You can see in your ET tube available, if it is available in front of you, or when you go to ICU or anywhere in emergency where there is ET tube, you can see that there are numberings labeled in those ET tube. And if there is displacement, so what we used to, after intubation, what we used to say is that we set the ET tube length at 14 centimeter. That is at the incisor teeth. So beyond, if the tube is out, suppose the tube we set is 14 and it come out to be 412. So in that way, we can say that the tube has displaced. Either it has displaced into the esophagus. If it goes beyond, suppose we set at 14, when we fix at 14 with equal breadths, suppose the tube goes to 16. So the tube can go beyond to other side of the lungs. Next one is by taking a stethoscope and then check for air entry on both sides of the lungs and also in the stomach area, that is in the epigastrium. If you can hear air, the sound of air or the breath sound equally on the epigastric region, that is in the area where the stomach is, and on both sides of the lungs, you have either equal sound of air or more sound on the epigastric region, then you should suspect that the tube might be displaced. Yes, like check the number that being fixed. Very good. Check the number. Volume is by auscultating. Check the number. Auscultating and using ambu-bag for checking the chest rise. Very good. If there is chest rise while doing ambu-bag, also you can check the chest rise and regarding the stomach rise. Next is obstruction. How do you check obstruction? Now suppose while doing an suctioning.
Let's ask you, how you will check the obstructions? First, let's hear from you all. No? How you will check?
Very good. Suctioning.
Okay, suctioning. By suctioning. Okay, I have 1,000 participants, so I want a more response here. Okay, by suctioning. Air entry check by ambu.
Anything else?
Ventilator alarm.
Ventilator alarm.
Other than suctions. Ventilator alarm, thank you. Suction.
Okay, using ambu-bag and suction. Okay. How then, what do you see while doing suction?
What do you see? I think this
What do you
suctioning
see?
and also you all are doing, I mean, in day-to-day life, no, those who are here having ICU and all. Usually when
One is
you are
resistant, yes. Suction, air entry, ambu-bag. That is one. Air entry and suction.
Resistance,
Thick secretion. Resistance, yes.
Obstructions
While inserting tube.
Resistance, secretions.
But no one has told what else you should check. Okay, I'll tell. Number one, all you have told regarding suction. Suppose when you put the tube, so what is very important is that this is suction tube, although this does not have any marking, but ideally you should use which has marking in centimeters. In an ET tube also, outside the mouth, there are usually markings here. There are markings here in as 22, 23, 24, 25, like that. In the ET suction tube also, you should have marking beyond the length of this ET tube. So
20 centimeter it should go.
20 centimeter.
Okay.
It should be like this. When you see 20 centimeter, it will be different for pediatric ET tube. It will be different for other tube. And if you cut the length of the ET tube, then it will be decreased. So in universal 20 centimeter, it's not universal for all. But what is important is for you to see. Number one is you should have a number tube, the tube which has numbering labels. And while you're putting inside, you should twist the tube. That means you should rotate while putting inside. And the tube should not be fully covered the inner diameter of the ET tube. So it should at least one-third of the diameter of the ET tube, it should be free. That means 2/3 it can be covered by the ET tube, by the suction catheter. So while inserting, you should twist or you should rotate the ET tube. And while rotating like that, this is what I have here is a non-corrugated, non-labeled tube. Ideally, it should non-labeled tube. It should be with labels. So suppose this is the here 20. What you will see is that here the tube, ET tube, you will see here 24 centimeter. And inside, all ET tube are transparent, which you can see even this ET suction tube also, you can see the number through this transparent ET tube. So while inserting inside, you should rotate, and at the same time, you should see the number. On this ET suction tube, it should correspond with the number here on this ET tube, or it should be 1 centimeter beyond. Suppose the ET tube, you see the number here is 24 here.
Okay.
I'll just show here. Suppose this is 24 here. Suppose this is 24 here, and the ET tube, this suction tube, it should go, and if you see through the transparent ET tube, the number on the suction catheter, it should be level, or it should correspond with the number on the suction catheter, that is 24, or 1 centimeter beyond, that is 25. In that way, you can say that there is no obstruction in the tube. That is number one. I'll repeat again. The number you should see on the ET tube should correspond with the number on the suction tube, either the same number or 1 centimeter beyond. Because once you put inside, this will correspond with the length. This is 24, here also will be 24. And if you go beyond, so the tube, the ET tube will come out beyond the tracheostomy tube, but it will not touch the carina. If you insert beyond, suppose 2 centimeters, so what will happen? It will touch the carina, and you will stimulate the patient and produce cough or vagal stimulation. So the patient might go to bradycardia also. So that is very important to check the numbering. Another thing is to detect obstruction is that while you inserting, if there is a resistance, like most of you have sent it, and suppose this tube has no numbering. So what you can do is that in that ET tube, you should measure with an inch tape. You take the inch tape and then you measure from this 22 centimeter. Suppose this is 27 centimeter till outside this one, till outside the ET tube here. And in an ET tube, you should know the total length. You can take one usable same ET tube and you should measure from here the whole length of this transparent tube. And from this, you can minus how much. Suppose this, after taking 27 centimeter, after taking this much, after you measure, then it will come out 8 centimeter more. 8 centimeter more. That means 35 centimeter. So the tube should be at least 35 centimeter here or beyond 35. Then suppose this is a 45 centimeter. Then what you can do is that you can take an inch tape and then you measure 10 centimeter from here, and then you can label. You can put a pen or a mark here, either with a blade not to cut the tube, or you can put one marker, because beyond this You should not go inside the ET tube. So what you can, after putting a mark here, then you can insert the tube and see that this mark area here, it should correspond with the outside of this this ET tube. So in that way, even without this mark ET suction catheter, then you can know that beyond this, up to this point, the ET tube should go such that you will know that there is no obstruction. And beyond this one, if you go 1 centimeter beyond, that means there is patency of the tube. Suppose if you cannot go beyond, then there is the patency of the tube is altered or hampered in that way. And another thing is to check obstruction is by ambu-bag, but and auscultation. During that time, you won't be able to hear the breath sounds on either side of the lungs. Next is pneumothorax. How do you detect pneumothorax? Anyone can tell?
You can write down in the chat box. SOB. Shortness of breath, chest X-ray,
Decreased breath sound,
disseminated,
CT scan.
diminished breath sounds.
These are all these are sudden desaturation, and you should detect it over there. You should not wait. X-rays will take more time, will take another half an hour or 15 minutes. Or if there is an X-ray on bedside, it will take 5 minutes positioning and plug in absent breath, affected site, shortness of breath, auscultation. Yes, CT thorax, it will take, you cannot take the patient to CT thorax if the patient has pneumothorax at that time, low SpO2, auscultation, percussion. Okay.
Sharp chest pain, shortness of breath, tapping, shortness of breath, auscultation, tachycardia, chest pain, shortness of breath.
What you can do, number one, is that when the saturation drop, how do you check when there is, after checking this displacement, obstruction, what you need to check is pneumothorax. Now pneumothorax, how do you check? One is, while you auscultate, also you should listen whether breath sound are equal or not. If they are equal, if there is unequal breath sound, then you should suspect pneumothorax and you should put a needle. You can answer where you should put a needle. Emergency, what is called as emergency thoracocentesis, which is what is the site of insertion? You can type on the chat box.
Second intercostal region.
Now, how do you detect? While you give the answer, I'll be explaining how to detect pneumothorax. Number one, you can use is a torchlight. Suppose this is a torch. This is usually what is important is a pen torch. So in neonate also, if you look at NRP, you can detect with a pen torch. So what you will do in a dim light environment, switch off the light. What you can do is put in the intercostal space. Suppose this is the intercostal space. You put a torch like this on that side. And then after putting the torch, what you will see, that side of the chest where there is pneumothorax, that will become more brighter. There is trans illumination on that part of the chest. In that way, you can detect, you can say that there is pneumothorax. Before putting, while you are arranging a needle for inserting into the, or while doing emergency thoracocentesis. Another after auscultation, after this one, and next after putting torch. And what you can do is percussion. So while percussion, there will be hyperresonant on that side where there is pneumothorax. And while putting a needle, all of you have answered, it's not fourth intercostal space, it is the second intercostal space in the mid-clavicular line. That is for inserting emergency thoracocentesis. So what other instrument do you need for while inserting? One is a needle, wide bore needle, usually of 18 gauge or 16 gauge needle. Then another tube is there, or what you can use is an IV set. One IV set, one part you put, one end you put with the needle, you attach to the needle. The other end, which you took out from that regulator, you put in an underwater seal. Underwater seal, either NS or distilled water or any water if you can find as early as possible. Suppose there is no NS, you have to ask the patient to buy, or you don't have NS, you have only D5, or you have tap water also, but that tap water should not enter inside the thorax. So in that way, you should put under seal water, and then you should look for, at the same time, while you prick inside perpendicular at the second intercostal space, mid-clavicular line, you should look for bubble. If bubble is there, it is suspected to have pneumothorax. And you should keep the needle there, inform the doctors or surgeon, and to put an ICD tube. Next, if a patient goes to sudden desaturation, equipment. Now, sometimes what does it mean here is that equipment. Suppose patient is having very ARDS. You say that equipment. How do we know that it's because of equipment or because of machine? Machine is working properly. If there's sudden desaturation, that means the pressure, the patient might need more pressure, or the patient might need more PEEP. So in that way, we can adjust the settings in the ventilator. And above seeing the equipment, you should check, number one is the oxygen port, the mid-air port, is it attached properly? Is there any leakage anywhere? And while seeing the equipment, you should put the patient on ambu-back, give ambu-back ventilation to the patient. And also with the test lung, you should check that the test lung should be inflated with every breath that the ventilator is giving. Next is stacked breaths. What do you mean by stacked breaths? Anyone can tell?
Write down in the chat box.
What do you understand by stacked breaths?
Have you heard of stacked breath? Continuous bubble suspension pneumothorax. No idea.
What are stacked breaths? Now, why do we have synchronized? This is because to tackle with these stacked breaths. What are stacked breaths? If the ventilator is giving pressure inside the patient, and at the same time, while the ventilator is giving pressure inside the patient is exhale out. Suppose the patient sedation, suppose midazolam or any sedation medicine is finishing, and then you didn't change, and the patient consciousness or sensorium return. So what will happen? The patient will try to breathe by self. If the patient breathe by self, so what happened? During exhalation, there will be pressure increase. There will be throwing of pressure towards the ET tube. And the ventilator also is giving pressure towards the patient. So what happened during the time that breath by the ventilator? What happened to that breath of the ventilator? It's not going inside the patient, and there will be desynchronization. Another word for stacked breaths is desynchronized breath. So what will happen during the time? There is fighting of the ventilator with the patient. So what do you need during that time is that you take the patient out of the ventilator, put an ambu-back, see the breaths, spontaneous breaths by the patient, and then watch out for those spontaneous breaths. And if the patient takes more of spontaneous breath, meaning that the patient's sensorium has returned back the sensorium, or the sedation is inadequate for that patient, there is fighting of ventilator with the patient. In that part, what you will do is that put the sedation more, increase the sedation of the patient, and put back on the ventilator. Now there is another S. After this displacement, suppose the tube is in place, or you suspect displacement, you re-intubate. You have tackle displacement. Obstruction, new ET tube, there is no obstruction, or you have tackled the obstruction. Pneumothorax, you have checked pneumothorax, you have put needle on both sides of the chest, there is no pneumothorax. Equipment is good, and then the patient also, no stacked breaths are there, or there is no fighting with the ventilator. There is and still the patient goes to desaturation. So what is another thing which can cause sudden desaturation?
You can write down in the chat box. What was the other reasons which will cause desaturation?
Apart from all these 5 parameters, there is another S.
Another S we have not mentioned here. You can write down in the chat box. Obstructing.
Obstructing, there is already obstruction. DOPES. Another S is there.
The tube displacement.
That already
Displacement
discussed.
Yes.
Hyperthermia.
It starts from S.
It starts from S.
Suctions. Suction secretions.
Suction, secretion, all these are obstruction. We have
Obstructions.
tachyline obstruction.
Saturation.
Saturation, you have seen equipment, long time suctioning, this one after ambu bag, checking the equipment, all those.
Sedation, synchronization, sedation, secretion.
Sedation, in stack breaths, you have tachyl. You take the ambu bag. After all these, you take ambu bag, you give ambu bag to the patient with its tube and chest rise is there. But patient still saturation, you give 100% oxygenation, there is no displacement, there is no obstruction, there is no pneumothorax, equipment is good, you have given 100% FiO2, stack breaths are not there. What else you should check? The last S.
Shock.
Yes, very good. Shock. 2 people have. One is shock. Why? Because ventilation, what happened in oxygenation? It requires one is an intact circulation. So if the patient is in shock, so what happened? There is less travel of oxygen, or the oxygen delivery will be hampered even if all the ventilation are good. So very important is to check shock state in a patient. Check the BP, increased heart rate, hypotension, cold peripheries, delayed capillary filling time, and even low pulse volume. So all these are shock, or color of the patient also. So the next S is shock. So these are, when the patient goes to sudden desaturation, you should check all these DOPES, and another one is shock. That's all. Thank you. If any question, then you can ask.
Yes. Oh. Thank you, sir, for the wonderful sessions. Now we will open the sessions for the discussions. If any of you have any queries, you can write down in the chat box. And even if any one of you have a good experience with the ventilators, and you have good stories which you want to share among other nurses, you can write down in the chat box, or you can raise your hand to, so that we will give access to talk. Write down in the chat box. If you have any queries, you can write down in the chat box. I know for most of the people, this is a very new topic, those who doesn't have ICU and all, but
regarding weaning off from ventilator, though it will be discussed in next session, but for today, weaning off, what you should need, number 1 is minimal settings. FiO2 should be on room air, that is 21%. The PEEP or the PIP should be minimum to maintain ventilation for that patient. Number 3, the settings. These are the settings which I'm telling about. The FiO2, the respiratory rate, there should be spontaneous breaths. And the PEEP should be minimum, that is minimum 5. And most important is you should check that the patient the respiratory illnesses should be resolved, and patient consciousness should be normal, or the patient should be awake or normal. And all the other major illness, shock, should be corrected without inotropes. And all the other illnesses of the patient should be in a resolving state.
Okay, so another question is asked by Iris. Sir, in the ventilator, the alarm will always show a high volume. So what to do in that case?
In that way, you should check why there is a high volume. The ventilator, if it shows high volume, that means there is an obstruction. Number two, you should check high volume. What does it mean? That means there is when you put more pressure, so what happened? The lungs should inflate. But what happened when there is why did the ventilators tell high volume? Because when you put more pressure, so the volume also increase. In that way, that means the ventilator will sense volume, meaning that either the patient there is dysynchrony, so there is a stack breaths. Number two, that means there it might be stiff. There might be the rib cage compliance is low, so the rib cage is stiff. And third, what you should see is that the alarm, which you said, is it normal or not for that patient? So these are the parameters you should check when the high volume, when the alarm goes as high volume for that patient.
Okay, I think Iris, you got the answer. What to do if the tidal volume is high, which is asked by Diamond?
If tidal volume is high, what you should check is the number one first is the tidal volume for each and individual patient according to the age, according to the weight, and according to the illnesses of the patient. Like you have seen before that for a normal lung is between 10 to 12 millimeter of ml of per kg. And in ARDS, it is 4 to 6 ml per kg. So depend on that, you should adjust the tidal volume. If the tidal volume, suppose in a pressure control, the tidal volume is high, the alarm comes out that the tidal volume is high. Like I said before, why there is an alarm, there is tidal volume, you should check for obstruction, you should check for all those compliance of the lungs, all these you should check. SMP mode then up down. This one.
This one.
Some SMP mode I saw.
Those who have submitted, no need to mention here that you have submitted.
Which
Okay.
is most commonly used for intubation, cough or uncough. Regarding ET tube, regarding cough or uncough, it depends. Suppose in neonate, we usually use uncough ET tube because the lumen, what do we need is a size of the ET tube, which larger size of the ET tube. Suppose if you have, if you don't have, what we suggest is the size of the ET tube. It should be almost covering up to 4/5 of the diameter of the trachea, such that there will be minimal leakage of air. But if you don't have a cuff, or if you don't have an uncuff and the size, the tube is less, then what you can do is the ET tube is use a cuff ET tube. What does cuff ET tube do apart from uncuff is that cuff ET tube, it will prevent oral secretion from entering into the trachea. That is the advantage of a cuff ET tube. And before removing or before extubating or weaning off with an cuff ET tube, what you should do, you should do proper suctioning, especially the oral secretion, such that whatever secretion remaining above that cuff, it should be taken out before extubating the patient.
Okay. So I think you got the answers. So next question is asked by Vinita. Cannot we use a ventilator without flow sensor in case of emergency?
In emergency, flow sense, how to detect flow sensor, it's very important because it will prevent inappropriate pressure to the patient and further to prevent polytrauma or barotrauma. So it is important. If you cannot have a flow sensor, what is safe is to put an ambu bag or a pain circuit and look for the chest rise. There should be adequate chest rise of the patient and the saturation should be maintained for that patient. In that way, you can maintain the ventilation in that patient.
I think, Vinita, you got the answers. So next question is asked by Pramila. Sir, what total inspiration should not go below?
Like I said before, inspiration time should not be below 0.4 seconds. Like what was the normal PEEP and PIP for the baby? For preterm baby, the normal PEEP, it should be 5. PEP, PIP, we can start with 12. Well, after that, then we look at the saturation. For both term and preterm, we start with 12 PIP, and for PEEP, we start with 5. And we look at the saturation, whether saturation maintained and circulation also is maintained.
Yeah. It's all. Anyone wants to ask any questions? Because I have not seen any more queries in the chat box. Post this link of yesterday. It's in WhatsApp group. Every after sessions, I used to post in the WhatsApp group. Please check in the group. In any of the group, I have shared the post-its and the feedback. I think it's. I've not. Yes, we can.
Anyway, thank you for patient listening, and thank you, Miss, for this time.